but Mara's busy, Misha.
Everybody's busy.
I know. And so
Catherine is
Catherine,
busy. She's here.
I know, and that's why
Commitment.
she's another rock star. So she's going to be doing our mind body practice. Misha?
All right. I'll try to be brief, but there's some kind of an important updates. So two main things. One, I brought up a point yesterday. The feds were gearing up to start putting general recommendations for the frequency of the ongoing vaccination, as well as the who should be getting the vaccine. Sorry about the mess. I was supposed to be skiing, but it's too cold to ski, so I'm here with all of you. So anyway, the January 26th, there was a federal vaccines and related biological products advisory committee meeting. To my pleasant surprise, they basically said exactly what I told you last week, which is expect a recommendation is going to be an annual boosters to only people at high risk. That's pretty much it. So they're probably not going to recommend boosters for the entire population. Or maybe they will, but they will be taking it a lot into consideration and will start out with just giving everybody an idea on annual boosters. I find it interesting that they're proposing a potential timing for boosters in the spring versus the flu in the fall. I kind of wonder if the whole story is going to be linked to the next topic, which I'm about to talk about. So the second topic is this. So those of you who've been following news pretty closely may have seen this kind of not necessarily very pleasant article. Everything's in the chat. And that is that there was an initial signal on the assessment of the ongoing COVID vaccine database side effects, that there was a potential signal for increased risk of stroke after the COVID shot. So the feds jumped on this quite aggressively. It took them less than 2 weeks, which is, I find, kind of impressive, to basically come out with an updated statement, which I'm putting in. I'm putting news articles in just because I find that they're much easier to read rather than like a formal statements. So basically, they're saying there's still a very weak possibility of this. And what they're now concerned more is that potentially that link is linked to combination, when people were getting a flu and the COVID at the same time. Those of you who've been following my work know that I always aggressive about saying, do not combine the vaccines, space them 4 weeks. And the reason is we've seen this kind of uptick in side effects in the double or triple vaccinations before. So I've been more cautious than others, saying, let's split them up. So I wonder if the feds are now saying, let's give the COVID boosters in the spring and flu shots in the fall as usual, partially going to be linked to this. So I think it will take at least another X number of weeks before we're going to hear kind of a more concrete, conclusive data. But nonetheless, stay tuned. If indeed the risk of stroke is real, I would like to find out as to what exactly that increase looks like, rather than just having the information of a weak link. Doesn't tell us a lot. Just accidentally, I had a patient a couple of weeks ago who had a stroke a week after getting COVID shot, young person. Does it mean anything? I don't know. But we have to keep an eye on this topic. All right, that's all I have. Questions in the chat before we move to Ashley's topic of long COVID. And by the way, we've settled down on our date for the next CIM open house, which will be on long COVID, and it will be February 24th at 11 a.m. So we'll send everybody updates, but I'm gonna
is that already on your website?
Not yet. We just finalized. Actually, Ashley and I have not even sort of finalized the actual agenda. We just gotten the dates organized and got people in to join. It'll be like about 30-40 minutes of updates and then Q&A for half an hour or so.
Cool.
All right. What is an adequate amount of time between flu shot and COVID boosters? Your guess is just as good as mine. I tell everybody minimum 4 weeks. I'm guessing more is better, but as always, good, tough questions. I think it has more to do with the expected a tiny post-vaccination inflammatory spike. I'm guessing that the 4 weeks is sufficient, but it's a guess. Well, they're only seen it with Pfizer vaccines because I think they mostly looked at that. They started noticing the signal with Pfizer. So the feds are now saying they will look into the Moderna, but they haven't. So I expect we're going to see the same. So it's just the way they looked at the data. That's why they only seen it there. Okay, and by the way, I don't know if I mentioned it, but I think I did. This new recommendation from the FDA panel is basically going to say boosters only once a year. Nobody's going to be getting boosters twice a year. And I've been talking about this now for many, many months. I have a lot of people call me and say, where's my 6 months booster? And I say, I don't know what you're talking about. There is no 6 months boosters. This was predating the kind of collective data now saying that probably unnecessary to give twice a year because you're not going to, even if you get somewhat better protection against the actual getting COVID, you're not getting a whole lot better protection against any complications or even possibly long COVID. So I am not sure that I will recommend anybody, even people at the very high risk, to get shots twice a year. It probably we would need to wait for a final rex, but for now, this is what we have. Is the risk of stroke just in? Yeah, that's what they think. It's within 2 to 4 weeks, within immediate to up to 4 weeks after the shot. So that's how the information started getting concerned. There were some preliminary reports by some large institutions that seen some patients report to the emergency room within a very short period after getting a shot. And some of those patients were pretty young. That was the concern. And then I guess the signal went up to the feds, and feds started investigating it sometime, I think late last year in December. And so then early in January, mid-January, they reported a possible signal. Then they investigated further. Looks like the signal is decreasing. They are now claiming that the signal in young people that is not present, that the signal, if anything, present only in seniors. So again, stay tuned whether that's true or not. Is the annual, I'm presuming you mean annual booster for seniors too. Yeah, so I think that the way this is all heading for now is that they're eventually going to select a group of higher risk people and only boost those. At least for now, that's how I read the Fed's report. That they're actually going to try to come up with a particular populations. They're not going to. So basically what I'm trying to say, there's been a lot of debate whether or not, say, young adults in college should be boosted, right? Because one thing is a public health, okay, let's boost everybody so there's less transmission. But then it's also an issue of complexity, right? I mean, you're going to start giving everybody on campus vaccinations. There are going to be some people who wouldn't want to do that. If you mandate it, there's going to be pressures and potentially tremendous psychological downfall. So there's been a lot of negative press on this. And I think the feds are carefully looking at kind of all the end spectrum points here and saying, look, if we're going to just blank to give it to everybody, and then the schools and every workplace is going to mandate it, we're potentially going to have more problems on our hands, which they're actually correct. There's going to be a lot of people rejecting the vaccines. And if you're mandating, what do you do with those who's rejecting? Let me give you a very crazy angle. So like I know a massage therapist who refused to get vaccinated so he can't get licensed. So we're going to start having a lot of really difficult ethical issues on our hands, and they're potentially going to have a serious long-term downfalls, not just psychological, but medical too, on both spectrum, both ends. So that's the problem. Okay, good news, though, I've read regarding long COVID Omicron, correct. I completely agree with Elle. I think I spoke about this last week. It seems like we're dropping the risk. It's going down. It seems like that most patients with Omicron, post-Omicron long COVID self-resolve without a lot of treatments. So I think some good news there, agree completely. So when does a senior who had a booster in the fall get the next booster, 6 months or what? No, that's what I'm just saying. If you got a booster in the fall, you should get the next one in the fall next year. But you would want to separate that booster by at least 4 weeks from your flu shot. The flu shot, I recommend people get sometime not earlier than October. So you can get your COVID booster in September, and then like early September, and then maybe late in October, get your flu shot. So that's kind of how I will be starting to, at least for now, until we get more data. Let's do this as a last question, because I don't take too much of Ashley's time. If someone had COVID this past fall, do you still recommend they get the bivalent booster within about 6 months? Or yeah, no, this is a little different, right? Because this is a situation where if you have not had a bivalent booster, you may want to get that one a little sooner. So that's a good question. I got my last one. Nobody, don't type anything. I got my booster in September and got my flu shot in October. All right, thanks. Okay, with that, Ashley, thank you so much.
Sure. It's a COVID type day, I guess, right? We're going to continue that conversation. And I have some slides that I'm going to share. So let's do that. I promise it's not too many. Whenever I see slides as a participant of something, I always think like, how many are there going to be? But don't worry, there's not that many. All right, let's see. So I'm going to talk a little bit about our clinic, but I'm also going to talk a little bit about long COVID and what we sort of know about it at this point, because it has been, a few years now, and the research is starting to sort of develop and flourish, and we're learning more and more about it. So what are some statistics related to long COVID? Yes, it is true that some of the data coming out about Omicron does look better. However, the data about reinfections does not look so good, despite people who are triple and quadruple vaccinated. It doesn't seem to make too much of a difference, unfortunately. So statistics remain the same, that 1 in 5 people between the ages of 18 and 64 have at least one medical condition that's related to COVID within a year of being infected. And 1 in 4, of course, if you're over the age of 65. That statistic has been around for, I think, about 6 months or more now, and there hasn't been anything new that's come out. So really that translates, if you're being conservative, about 65 million people worldwide, but probably more than that. And most of the people, this is a question that people ask quite a bit, like, how severe does the infection have to be? Most are actually non-hospitalized, pretty mild infections, and most people are between the ages of 36 and 50. So a little bit on the middle-aged, younger side. But what I think is even more important than any of this is that currently, and this is a newer statistic, 4 million people are out of work due to long COVID. So we're not just talking about like a medical impact. I mean, that's a huge economic impact to our country. And I think that's why on a federal basis, they're putting some money into it. I would argue not enough, but they're putting some money into it. So we will see what happens with all of that. So basically your risk increases with new infections. If you look at these charts here, in terms of like initial infections versus breakthrough infections, these are bigger manifestations, things like death, heart failure, cardiac arrest. We're not just talking long COVID in terms of some of the other lesser symptoms, but your risk does increase even with, having more infections, despite being vaccinated. I think what this data does show is that there's still, an importance of precautions. Doesn't mean that you have to be wearing a mask 24/7 all day of your life. However, I would say the data supports probably when there are increases in infections, when you start to see that those numbers go up or trend up, that might be a good time when you're in crowded places to start wearing maybe a mask, especially if you're somebody who's high risk. Or has other medical conditions. Being on a plane, that might be a good time to wear a mask as well. Risk factors of long COVID, being female, not much you can do about that. Being a type 2 diabetic, ADHD is actually a risk factor of long COVID, chronic urticaria, some autoantibodies. But 1/3 of people who get long COVID don't have any risk factors at all. But I think on top of this, it's also good to mention, I always try to make a point to mention this, that we don't want to forget about the socioeconomic risk factors, right? People who are low income, Mainly people who have an inability to rest after infection. Ethnicity-wise, this is a huge problem in the Hispanic Latino community. I remember even in the earlier days of working in urgent care, I worked in a lot of the areas that had a huge Hispanic Latino population. And, unfortunately, they were like, there is no COVID protocol at my job. If I don't go to work with COVID, then my family doesn't eat, right? And so many people just kept working. And unfortunately, that leads to more long-term COVID complications. So what do we kind of know about the underlying mechanisms of long COVID? Well, here is a few. And I would say that there's probably many, many more hypotheses about what is sort of underlying what is long COVID, right? Because what we know about it, or many of you may already know, is it's a constellation of symptoms, sort of like a syndrome. So, some people have fatigue, headaches, cognitive dysfunction, heart rate changes, chest pressure, breathing problems. The list kind of goes on, and everybody is a little bit different. But these are sort of the underlying mechanisms. I'm going to talk a little bit about a couple of these that you see pretty often, or I see in my practice pretty often. One of these is immunology and virology. So you definitely have these reactivated viruses. We see this quite a bit, especially with things like Epstein-Barr virus. And HHV6, if you guys aren't familiar with that, that's like kids get that, like roseola, that rash, that's caused by HHV6. And that one tends to kind of come up too as a reactivated virus with things like COVID. These reactivated viruses lead to mitochondrial dysfunction, which is really something that you can do many things about, so that's good. And then, other manifestations in the immune system. So I put this little nifty chart in here about innate and adaptive immunity. It gets a little complicated when we see these charts, right? But basically it exhausts the T cells, increases mast cells, elevated cytokines. Some of these things you guys may have heard on the news when you think about people who, die of COVID, right, acutely. They have the cytokine storm. I think many people have kind of heard that word. And if you look here on this chart, it kind of shows you how that leads up. And then the last thing is viral persistence. A lot of people ask about viral persistence. And there is some truth to it. I don't know if we know everything about it, but in some studies, 60% had spike proteins up to 12 months. And that's pretty much when the study stopped. So we're not sure if it even goes beyond that. It very well may. And then we have to think about, should we be treating that, and how should we be treating that? Another, hypothesis that's really popular, and I think Sinai is actually doing a very large microclotting study going on right now, is vascular damage. Thing about vascular endothelial damage, which is what lines our blood vessels, is that it affects the entire body, right? Because we have blood vessels everywhere. So huge systemic consequences to this. This is kind of what's underlying that large VA study. I don't know if many of you have seen this, but the VA has kind of been a front runner in a lot of these long COVID studies because they're doing like medical record evaluation. So it's very large studies of, over 150,000 people. And they noticed that there's a cardiovascular disease risk 1 year after COVID. That's pretty significant, including things like MI, strokes. And so we do have to kind of keep that in mind. There are some limitations to that study. Most of the people in the VA are male as well. So that is something to think about. And they may have had some other risk factors too. So always good to kind of keep in mind whenever we see this data, what are some other biases to it? But the VA has been one that's been doing a lot of research. So the endothelial damage can be caused by inflammation, but COVID-19 can also infect endothelial cells pretty directly too. So something to think about. I put a little chart there about about clotting factors and kind of how that all works. So neurological and cognitive is a huge piece of long COVID. I'd say that in the majority of the people I see, we see something in this realm, whether it's fatigue or it's brain fog. That's pretty common. A meta-analysis showed that fatigue is in 32%, cognitive impairment 22% 12 weeks after infection, so about 3 months after. One report, I think this is kind of interesting, of 1.3 million, which is a large sample size, showed that mental health conditions related to COVID actually returned to normal over time, while cognitive impairment persisted for at least 2 years. So 2 years, that's not a short period of time. That's really going to be debilitating. So I thought that was sort of interesting. The UK has kept this biobank of brain imaging. That's interesting to look at, where they had participants before and after COVID. And these people don't even necessarily have long COVID or self-reported long COVID. They just have had a COVID-19 infection. And it showed reduced gray matter thickness and overall reduction in brain size, that's pretty significant. You know, what the long-term consequences of that are, we're not sure, but definitely not a good sign. And, you know, the mechanisms behind this might be neuroinflammation, could be damage to the blood vessels, like we talked about, injury to neurons. So something to kind of keep in mind. Another issue becomes ME/CFS, which we see after a lot of different viral infections, and dysautonomias as well. So dysfunction of the vagus nerve, right? And the problem with ME/CFS is that statistically 75% are unable to work full time and 25% are bedbound. So that's some pretty sad statistics, and kind of maybe matches up with what we know about long COVID and people being out of work. You know, is ME/CFS behind the reason why they're unable to go back to work? That could be the case. Not really surprising though with COVID-19, because the SARS-CoV infection, so the first one that existed, right? Not SARS-CoV-2, but SARS-CoV-1, the data from that infection showed that 27.1% of survivors met the criteria for ME/CFS after 4 years of onset of their infection. So we would probably, you know, assume to find something similar in SARS-CoV-2. And there's similar findings too, objectively, between long COVID and ME/CFS. There's mitochondrial dysfunction, there's altered fatty acid metabolism, lots of endothelial damage, cerebral blood flow abnormalities. There was one cohort study that found that POTS was present in 67% of people with long COVID. So that's kind of a scary statistic as well. And small fiber neuropathy and MCAS are also comorbid with these conditions too. So something to kind of look out for. I put a couple of things about the gut. The gut is a huge problem, and they're still kind of, you know, they don't know. It seems like with the gut, they know the least amount when it comes to long COVID. I'm not sure why, but hopefully more research is put out specifically about the GI system. But we do know that the gut microbiota is significantly altered with COVID-19. And some studies have shown that this sort of like dysbiosis lasts for at least 14 months. 14 months is a long time, and they've seen viral presence of this in the stool. So they've seen SARS-CoV-19 in the stool in 12.7% of people after 4 months and 3.8% of people after 7 months. So I think what this really does is tell us how important it is to take care of our gut, especially when we have an acute infection. So this is a really overwhelming chart, but I kind of like it because I think this is how most long COVID clinics are sort of managing people with long COVID, sort of your conventional, you know, Hopkins or MedStar clinic are doing many of the treatments on this list. Most of the research you can see of where these treatments came from was actually ME/CFS literature. So that's kind of interesting to see that connection. It's not really coming from, you know, long COVID, because long COVID hasn't been around as long, but really coming a lot from the ME/CFS or POTS literature that's sort of already out there. So kind of interesting to, you know, leave it up for a moment so you guys can sort of look at this. In terms of low dose naltrexone, I thought was interesting because it's on this list. And many of the long COVID clinics I've spoken with, like MedStar, for instance, are not very comfortable with low-dose naltrexone. I don't think they're prescribing it yet, which is kind of unfortunate because it tends to be very low risk, high benefit.
Do you, Ash, why do you think that's the case? Because I mean, it
So-
doesn't make it, there's no risk here. So what are they afraid of?
They just don't know enough about. So when I talked to the director over there, I met them at the long COVID conference in DC. She had said that she's just not familiar with it. Although she's the director, she's just out of residency. So she's a brand new doctor and just doesn't have any sort of familiarity with it. So I really pushed her and told her, I think that you should be at least trying it. It's very, very low risk. And, you know, I think your patients could get a benefit from that. So hopefully they will kind of be looking at that. But from the patients I've seen that have been to that program, they're still not.
I think I'm gonna, can I take 30 seconds?
Yeah, take it. Yeah, go ahead.
So I just had a communication with the head of the Northwestern program and the University of Chicago Integrative Medicine Centers, or just by text. And both of them told me something that I think makes me realize what we're dealing here with. They basically both of the centers tried to create an ongoing complex program, and actually Northwestern created the long COVID clinic, but they're all struggling to keep them running because there's no additional funding, and it's such a complex administrative clinics that they're really struggling to create them efficiently. So what ends up happening here is a lot of the staffing occurs from people who don't need a standard high salaries. I think that's what's actually happening. So they basically getting people in who are right out of residencies because those are the kind of they willing to take anything on. So they filling the spots available. And then as a result, you end up with a lot of, you know, not that anybody here is experienced, but, you know, there's something to be said to the way that GW set up original clinic with one of the most experienced ID doctors being in charge. And then what happened after funding ran out? Well, it fell apart. So I think that's where the situation is. Again, it goes back to the lack of funding.
Yeah. Yeah, that is a huge problem. And that's probably why, you know, that person is in charge of that program. The Hopkins program is a little different. I mean, Dr. Azzola is in charge of the Hopkins program. She's pretty well seasoned PMR physician. And, you know, there is limitations in sort of physiatry and long COVID, of course. I mean, she's not a infectious disease doc by any means. But I will say that their program is a little bit more, I know that they're doing low dose naltrexone. They're a little bit more open-minded to just trying things and seeing if it'll work, because when you think about these people, you know, we talked about the statistic of people who are out of work, you sort of have to do something, especially if it's low risk, you know, even if you don't get the benefit that you're sort of looking for. So yeah, but it is unfortunate about the funding piece. But so yeah, I was sort of surprised that that was on the list here. Stellate ganglion block was also on this list, which is interesting. The only ones I know doing that for long COVID are Hopkins, and that does have more risk associated with it. So that's interesting. Vagal stimulation, many people are using that. So good to think about. So our approach a little bit is, you know, we definitely look at the whole person, of course, which makes us a little bit different. We're looking at sort of underlying cellular dysfunction, although many of these other programs sort of acknowledge that mitochondrial dysfunction is a part of it. I don't think that they're necessarily treating mitochondrial dysfunction or really even testing for mitochondrial dysfunction, because many of the tests for that are sort of functional, not covered by insurance, unfortunately. Or in the treatment for it involves a lot of different supplements and things that they might not be familiar with. We're also doing infusion therapies. A lot of the other programs aren't doing infusion therapies either. I'm a huge believer in all CAM modalities. So acupuncture, of course, is near and dear to me because I also practice acupuncture. But I refer my patients to other CAM modalities too, like cranial sacral therapy and somatic experiencing. I've seen a lot of really good benefit with long COVID patients and those other modalities. Massage in itself is really beneficial for long COVID. So I'm always referring my patients there. We do groups, which is really unique. We have a long COVID group that we do on Thursdays for an hour virtually. And it's a really good way to talk about integrative medicine techniques and also get people together to build a community. We use cannabis. I will often refer my patients to to our cannabis coach, Dr. Benavides, to get help with different chronic pain or migraines, or any way that we can kind of add something more natural into their treatment plan. And we have a really close relationship with GW Hospital in the rehab, which I think is important to say. We work really closely with speech therapy, occupational therapy, physical therapy, and we share a lot of the same patients. So that has been really helpful because that piece is hugely important in terms of people improving their overall quality of life, honestly. And I also put our open house on here too, that it's going to be on February 24th at 11. So are we sending out an email about that, Misha, or how's that working?
Yeah, we'll send an email to everybody, but also we'll put messaging about this next week, next 2 weeks.
All right, so I'm going to stop sharing, and then if anybody has questions, I'd love to answer them. Oh, the graphic, yeah. I always like that one. It is, yeah, a great pelvic floor. I have referred a lot of my patients for pelvic floor therapy. The COVID vaccine causing a reactivation of chronic viruses.
It's a good question.
That is a good question. I don't know if we know.
Yeah, I don't know either.
I haven't seen anything.
Okay, friends.
Looking into that.
Friends, it is almost 2:40.
Sure.
And it's time. Even this is fascinating, and so this just tells me that we probably need to have you back to talk some more about long COVID, Ashley.
Okay. I'm happy to be here for you guys anytime.
All right, thank you. Thank you for waiting, Catherine.
It's fine. No, this was a lot of really good information. So thank you, Ashley. And thank you, everyone. For those of you who've been with us before, I'll lead you through Mind Body, some different exercises. So I invite you first to get comfortable wherever you are. If you feel like you need to adjust your seat or the place where you're sitting, please feel free to, if you want to bring any blankets, pillows, anything to help you feel cozier, that might make this experience nice as well. So I'm going to start seated, feet planted firmly on the ground for the way my chair is setting. And because it's the afternoon and I don't know, I always get sometimes a little sleepier around this time, I invite you to just start, maybe just gently shaking out your hands. Just bringing a little bit of movement, but also maybe just kind of releasing anything from your day, from your week. Anything feels like maybe it needs to be stretched or moved, you can feel free to do that too. If you've been sitting for a while, ooh, feel it in my back. Just kind of letting go of anything so that when we're sitting here in stillness, we're a little more comfortable. Take as much time as you need and allow yourself to settle in a little more. And here I invite you to close your eyes or hold a soft gaze forward or keep your eyes open, whatever helps you feel most comfortable, most safe, and most able to relax. Take a deep breath in, inviting oxygen into your body. And exhale, sigh it out, let it go, release. Feel your body settle in a little more to the surface beneath you. We'll do this 2 more times, breathing at your own pace. Deep inhalation in through the nose. And exhale whenever you're ready. Letting it go, feeling your body soften. And once again, deep inhalation in. Exhale, release. And turning inward, notice the natural movement of your breath. Follow the path of your inhalation and your exhalation. Notice once you breathe in through your nose, where does your breath go? Can you follow the path? Or perhaps pay a little bit more attention to your breath and find the way that it moves in and however it chooses to move out. Perhaps notice as you breathe in and out, does your rate of breath change? Does it deepen? Does it slow down a little more? If there's anything you need to do to help yourself get a little more comfortable as you breathe, please feel free to adjust as you need to. We'll continue this focused breath work for 1 more minute. Taking your time, there is no rush. Just observe and become more and more aware of your breath in this present moment. I invite you to continue to breathe throughout this practice. We'll now move into a gentle body scan, bringing more awareness and attention to our whole body. Again, I invite you to make any adjustments you need to, as we'll be sitting here for several minutes. So just want to ensure you're as comfortable as you can be. We'll begin this scan first starting with bringing attention and awareness to our right hand. As I mention each part of the body, there is no need for you to bring any movement. Just bring awareness and attention here. Right hand thumb, index finger, middle finger, ring finger, pinky finger, right wrist, elbow, shoulder, entire right arm, entire right arm, left hand thumb, index finger, middle finger, ring finger, pinky finger, left wrist, elbow, shoulder, entire left arm, entire left arm, front of the neck, back of the neck, back of the head, crown of the head, forehead, right eyebrow, left eyebrow, right whole eye, left whole eye, nose, right cheek, left cheek, right ear, left ear, chin, jaw, whole face and head, whole face and head, throat, heart center, back of heart center, rib cage, stomach, hip bones, right hip, right thigh, knee, calf, right ankle, foot, right toes, entire right leg, foot, and toes, entire right leg, foot, and toes, left hip, left thigh, knee, calf, left ankle, foot, left toes, entire left leg, foot, and toes, whole left leg, foot, and toes. Become aware of the entire right side of body. Entire right side of body. Entire left side of body. Entire left side of body. Whole top half of body. Whole top half of body. Whole bottom half of body. Whole bottom half of body. Front side of body. Back side of body. Whole body. Whole body. Whole body. Breathe here in this awareness. Notice what it feels like to have all parts of your body aware, open. Does this bring any type of activation for you? What does it feel like to feel these parts of your body awakened and perhaps more present in this moment? Breathing in, breathing out. Continuing to breathe. I'll now guide you through a very brief image visualization. We'll name different things and just ask that you envision them in your mind's eye if it feels right for you. I invite you to incorporate as many senses as you feel welcome to use. There is no need to try here. Just allow these images to come to you as I repeat them 3 times each. Red petaled flower. Red petaled flower. Red petaled flower. Juicy orange fruit. Juicy orange fruit. Juicy orange fruit. Golden sunlight. Golden sunlight. Golden sunlight. Green petaled flower. Green petaled flower. Green petaled flower. Blue butterfly. Blue butterfly. Blue butterfly. Third eye chakra. Third eye chakra. Third eye chakra. Drop of water uniting with ocean. Drop of water uniting with ocean. Drop of water uniting with ocean. I invite you here to sit with whichever image or images resonate most with you. For the next minute, we'll start a timer. Just allow that image to come more and more into your mind. Or perhaps another image feels better for you here. Imagine breathing in that image, allowing it to fill up your whole being, perhaps bringing any healing that you need at this time. I invite you now to take a deep breath in. And as you exhale, exhale out this image, allowing it to release. Begin to deepen your breath a little more. And as you do so, bring movement, gentle movement into your body here. Any gentle stretches in your fingers, in your toes, in your wrists and ankles. Maybe any stretches overhead. Anything your body is calling for. Awakening your eyes whenever you're ready. As we return back together, still breathing gently in our virtual space here. Thank you.
Thank you. Thank you, Catherine. Thank you so much. Thank you, Ashley. It's always so relaxing to have you here and go into our weekend after. So we'll see everybody next Friday. What do we have next Friday? Jenny's still here?
Yeah, I'm still here. We have Ellen Goldstein, who is a licensed acupuncturist, educator, and she's the author of Food is Medicine. She's going to talk to us about eating for immune system support. And we have another new guest with us. That will be Eliza Schaft. We were exchanging emails with her earlier today. So she is going to eventually be doing wellness talks for us, but this time it'll be a guided meditation next week.
Great. Everybody stay safe, stay warm. If you're heading north, stay warm. Yeah. But I'll be heading.
If you're headed south, you got to stay warm. It's iffy down here in South Carolina. Bye, everyone.
Bye.
Bye. That was
You're in South
Salome.
Carolina?